Shotgun Q&A, let's go. Hello and welcome to Shotgun Q&A. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we'll look at 50 MCQ questions in one clinical course. And this is indeed the pilot episode. So if you do want such more videos, please drop a like, also drop a comment, share the link to someone who is writing exams, and grab your piece of paper, grab your pen, and let's go. Warning in advance, data will be flowing like rain, so you better be ready. Best be prepared. So before we actually continue, there are some ground rules that we're going to be following during this exercise. So the first thing is you're allowed to pause the video at any point before I give you the answer. This will help you, give you a chance for you to understand the question and for you to actually answer it and gauge yourself. Also, note down your answers and keep check of your progress. You should be marking yourselves honestly and then count your total out of 50. Then, of course, you should be able to grade yourself out of 50 at the end. So let's go. Question 1. A 20-year-old man comes in with a history of fever of several months, bleeding from the gums and pallor. His hemogram shows pancytopenia. What would be the most important investigations you would do? A. Bone marrow examination. B. Coombs test. C. Reticulocyte count. D. Serum folic acid levels. E. Serum iron levels. So you may pause the video right now. I don't have to tell you. Okay, so before I give you the answer, let's just go through the question. So this is a 20-year-old man, so it's quite young, and he's coming in with features of, let's say, his platelet count is low because he's bleeding from the gums and bleeding from, as well as having pallor. So it means that his HB is also low, and the white blood cells are also low. So it means that there could be a problem with his bone marrow. A Coombs test would only be effective if you are trying to find out causes of hemolytic anemia, for example, or any cause that may be causing hemolysis of the red blood cells. But the reticulocyte count also would just tell you that the bone marrow is functioning and synthesizing these red blood cells. The folic acid levels will just point you towards folic acid deficiency, and that obviously won't affect all the cell lineages to an extent of having a pancytopenia. Iron deficiency, like the same, would affect predominantly the red blood cells. So you would obviously want to do a bone marrow examination. So the answer is A. Question 2. In infective endocarditis, which of the following matches is correct? A. Janeway's lesions, erythematous tender macules on palms and soles, Osler's nodules, non-tender nodules on hands and feet, splinter hemorrhages, retinal bleed, the systolic murmur along the left lower sternal border, that's tricuspid regurgitation. So you may pause the video right now. Which one do you think is matched correctly? So if we look at option A, Janeway's lesions are actually not tender. Remember how I remember this? Osler's nodes, O for ouch, so they should be tender. So what they've described there, erythematous tender macules on the palms and soles are Osler's nodes. And then Janeway's lesions are non-tender nodules on the hands and feet. So A and B have been switched, so they are both wrong. Splinter hemorrhages are not found on the retinal beds. They are actually found on the nail beds. Then, of course, the answer would be D, meaning that a systolic murmur along the left lower sternal border is, of course, showing you tricuspid regurgitation. If you do not know about murmurs up to this point, I have released a video on murmurs. So just go to the IMED playlist and look for the video on murmurs. I will leave a card at the end of this video as well. Moving on to question 3, Asterexis seen in the following conditions except A. Hypokalemia, B. Uremia, C. Ventilatory failure, D. Barbiturating toxicity or intoxication rather, and E, none of the above. You may pause the video at any point. So recall that Asterexis, also known as flapping tremors can actually be seen in multiple conditions. They can be seen in uremia, they can be seen in hepatic encephalopathy, they may be seen in mostly metabolic disorders, they may also be seen in barbiturate intoxication. So most of these things that have been outlined on this question, you can present to you with Asterexis. Hypokalemia can present to you with Asterexis, uremia, ventilatory failure, barbiturate intoxication. But so it means that the answer here is going to be E. The approach I like to use for these questions is most likely if you see that 2 or 3 of the options that you have there are correct and you're not so sure about one of the options, then you could take a chance. It's a 50-50 chance. One time you may guess correct, the other time you may not, but you at least stand a chance of getting a better score at the end of your exam. Question 4. A 70-year-old patient has cogwheel rigidity and pill rolling tremors. The diagnosis is likely to be A. Alcohol intoxication, B. Stroke, C. Hepatic encephalopathy, D. Osteoarthritis, E. Parkinson's disease. So this is one of the questions where it's either you know it or you don't. There's no two ways about it. They've actually described to you one of the typical features that you see in this condition. Again, what gives away the answer is the age of the patient and the symptoms that the patient is presenting with. And here comes the answer. This is obviously Parkinson's disease. You may get some tremors in alcohol withdrawal syndrome, which is referred to as delirium tremens. And then you may get some tremors in hepatic encephalopathy, the so-called Asterexis, or flapping tremors. But with cogwheel rigidity and pill rolling tremors, you get that in Parkinson's disease. Recall that you also get tremors in patients that have cerebellar disease. But now there is a differentiation between tremors that we see in Parkinsonism and tremors that we see in cerebellar disease. By now, you should be able to tell the difference. If you do not know the difference, we are covering these topics in the neurophysiology lectures, so keep a lookout for those. Question 5. The commonest cause of TIA is A. Embolism from heart, B. Embolism from pelvic veins, C. Embolism from internal carotid artery, D. Hypotension, E. All of the above. And here comes the answer. So the most commonest cause is, of course, from the heart. And remember that this is obviously going to be in the background of either an arrhythmia or stasis of blood that's going to be happening in the heart. And this is going to be predisposing for clot to form in the heart. So it means that it can actually dislodge and go and block the blood vessels in the brain. It's known as a transient ischemic attack. So that TIA is a transient ischemic attack, where you get these focal neurological symptoms that often resolve within an hour, or at most within 24 hours. But most of them resolve within an hour. Question 6. A 66-year-old lady presents with tenismus. The condition is commonly associated with A. Hemorrhoids, A. Inflammatory bowel disease, B. Hemorrhoids, C. Cancer, D. All of the above. You should, of course, know what tenismus is. If you do not know what tenismus is, you can actually pause the video and go study. I'm just kidding, but you should know what tenismus is. Okay, so here comes the answer. So it's seen in all of these conditions. So recall that whenever you see such things in MCQs where you get 2 options that you really are sure of that these options do or die, they are correct, and then one you're not so sure, and then there's an all of the above option, it's most likely that the answer is going to be all of the above. So you can actually use this intuition to actually go through MCQs, and sometimes you can use this, what I call educative guessing, to actually do quite well at MCQ questions. It's not rocket science. Question 7. A 43-year-old man with a history of hepatitis C and current intravenous drug, I don't know what's happening to my reading today, uses drug use, presents with 5-day of fever, chills, headache, and severe back pain. On physical exam, temperature is 38.1, blood pressure is 109/56, pulse is 94, and respirations are 18. He is thin and diaphoretic with pinpoint pupils, poor dentition, and track marks on his arms and legs. A high-pitched systolic murmur is heard. loudest in the left sternal border and with inspiration. He is admitted and started on broad-spectrum antibiotics. One of the blood cultures drawn 12 hours ago returns positive for Staphylococcus aureus. Which of the following is the most appropriate next step to confirm the diagnosis? A. Repeat the blood cultures now. B. Repeat the blood cultures 24 hours after initial cultures were drawn. C. Repeat the blood cultures 36 hours after initial cultures were drawn. D. Repeat the blood cultures 48 hours after initial cultures were drawn. E. Do not repeat the blood cultures. So, what do you think the answer is here? So, this is a patient where they are a known drug user. They have a history of hepatitis C, and with a murmur, of course, thrown in there. They are sweating a lot. Their temperature is high. They are hypotensive. Systolic is less than 60. And they give you a positive culture for Staphylococcus aureus that was drawn 12 hours ago. So you can't wait for another 24 hours, nor can you wait for another 36 hours, nor can you wait for another 48 hours. Most likely, you're going to have to draw the blood cultures there and then when you get the result. So you would repeat the cultures now. Question 8. The following are features of grade 3 hepatic encephalopathy except A. Disorientation in time and place. B. Marked confusion. C. Amnesia. D. Somnolent but arousable. E. Hypersomnia. You may pause the video at this point. Recall that hepatic encephalopathy is a complication of liver disease, pretty much hepatic cirrhosis, where the liver is not able to carry out its duties of detoxification. So you have buildup of ammonia in the body and nitrogenous waste, which can actually cause a lot of damage, especially in the central nervous system, resulting in characteristic features that can be graded in terms of the grading of hepatic encephalopathy. So most likely amnesia is the feature that's not seen in grade 3. You should have a look at this grading. Just Google this after you finish these videos and actually note these things down so that you can use this as your study points when you are studying after this video. So question 9, an old patient presented in the emergency ward with history of weakness on the right side of rapid onset. The most helpful first-line investigation for management of this patient is A. Cerebral angiography, B. Cerebrospinal fluid examination, C. Computerized tomography, scan brain, and D. fasting lipid profile. And here comes the answer. So most likely, if we look at this question, this is a woman that has presented to you with focal neurological symptoms. So she has weakness on the right side, which is of rapid onset. So it means that she's having a stroke. Or most likely, TIA if it's going to be resolving within 24 hours, or a stroke if it's going to be permanent. So most likely you'd want to order for a CT scan. That's a computerized tomographic scan for those that do not know what CT stands for. So you're obviously going to order for that, and that will help you distinguish whether it is an ischemic stroke or it is a hemorrhagic stroke. Question 10. In the thrombosis of dash artery, the leg is weaker than the arm. A. Middle cerebral artery. B. Anterior cerebral artery. C. Posterior cerebral artery. D. Basilar artery. And E. All of the above. So this is a question that actually tests your anatomy and your blood supply to the brain. Remember your circle of Willis, that's going to be formed by those internal carotid arteries that are coming in, the vertebral arteries that are going to be also joining into the basilar artery. But the answer here is, of course, your anterior cerebral artery, because that's going to be supplying the areas of the brain that are responsible for the leg. And then also, just back on that question, the most common thrombosed artery in terms of stroke is actually the middle cerebral artery. Then question 11, Hemophilia B is characterized by deficiency of factor A, factor 8, B, factor 10, C, factor 7, D, factor 9, and E, factor 11. You may pause the video at this point. If you do not know all the clotting factors, then I'm sorry, but you can't really answer this question. But I have also done a video on clotting factors. So this is kind of like a revision of a lot of things that we are yet to cover on the channel and things that we have already covered on the channel. So remember that Hemophilia B is a deficiency of Christmas factor, which happens to be factor 9. You have Hemophilia A, which is a deficiency of anti-hemophilic factor. Then remember that Christmas factor is factor 9 that was named, of course, after the patient. Then question 12, the pentad of thrombotic thrombocytopenic purpura includes the following except A. Microangiopathic hemolytic anemia, B. Renal failure, C. Leukopenia, D. Thrombocytopenia, E. Fever. So remember that this is also a bleeding disorder. Thrombotic thrombocytopenic disorder is a bleeding disorder. So you have primary bleeding disorders, secondary bleeding disorders, and combined or mixed bleeding disorders. So most likely the feature that you don't see is leukopenia. So what happens in thrombotic thrombocytopenic purpura is you have these injuries for whatever reason to the blood vessels that are going to be resulting in formation of these micro thrombi, the small thrombi that reduce the size of the lumen. And remember, because you're using up these, making these thrombi, you're going to be using up platelets to actually make these thrombi. So that's going to manifest as low platelet count because the platelets are being used up. Then of course, as red blood cells are going through this, they can be hemolyzed. That's why it's called a microangiopathic hemolytic anemia, because it's affecting the small blood vessels. There are clots forming in the walls of the small blood vessels, reducing the lumen, causing hemolysis of red blood cells. So this is also going to further manifest as a drop in the platelet count. This can happen in the kidneys, leading to renal failure. It can also result in fever because of the hemolytic process that is going on, and as well as the process of thrombosis. Question 13. The most common inherited bleeding disorder is A. Hemophilia A, B. Hemophilia B, C. Von Willebrand's disease, D. Glanzmann thrombasthenia, E. Bernard-Soulier syndrome. Again, this is one of the things where you either know it or you don't. So the most common inherited bleeding disorder is obviously von Willebrand's disease. Question 14. Imatinib is a therapeutic option for A. Chronic myeloid leukemia, B. Acute myeloid leukemia, C. Chronic lymphocytic leukemia, D. Plasma cell leukemia, E. Chronic myelomonocytic leukemia. So again, this is also one of the things that you either read and know or you don't. So most likely this is a chronic myeloid leukemia. So imatinib is a drug that's used in the management of chronic myeloid leukemia. So question 15, concerning sickle cell anemia, genes that code for the defective beta chain hemoglobin are located on A. chromosome 16, B. chromosome 13, C. chromosome 11, D. chromosome 12, E. chromosome 15. So again, this is another one of those things. If you know, you know. If you don't, you don't. But remember that in sickle cell, you have a mutation on one of the chromosomes that I will give you the answer shortly that results in the substitution of the 6th amino acid on the beta chain, which happens to be glutamate. Remember that glutamate is a water-soluble amino acid, and it's found on the surface of the beta chain. And it's going to be switched out for valine. And remember that valine is hydrophobic. It is hates water. So it's going to change the shape of the hemoglobin, and this can actually predispose to precipitation of the hemoglobin and, of course, sickling of the red blood cells. And, of course, the defect is going to be found at chromosome 11. So the answer is C. Question 16. A 23-year-old presents with joint pains affecting her upper and lower limbs for about 12 weeks. She also feels fatigued and has Zika symptoms. She denies hair loss, rash, or fevers, but has morning stiffness. The patient above was noted to have tender third and fourth metacarpals bilaterally, tender knees, a low positive rheumatoid factor, and ESR of 67. According to the 2010 EULA ACR rheumatoid arthritis diagnostic criteria, what score does the patient have? Again, if you do not know the score, please check it out after this video, because each of these parameters are scored different things, where you have the duration of the time has a score to it, the involvement of small joints. Remember that there are 4 small joints and 2 large joints that are affected. There's going to be a low positive rheumatoid factor that also has a score. The ESR also has a score. So if you add those up, they give you 8. So this patient is at 8. Question 17. With regards to joints, the following are referred to as large joints except A. Knee joints, B. Hip joints, C. Wrist joints, D. Elbow joints, E. None of the above. So which of the following is not a large joint? That's what the question is pretty much asking you. I know these questions can sometimes twist your brain, but how I like to approach them in the exam is like I like to ask myself the alternate version of the question. If they ask me which question this large joints except, so it means the question is in essence asking me which of the following is not a large joint. So the answer here is obviously C. The wrist joints are not considered as large joints. Question 18. Which of the following is a correct match in relation to modes of joint involvement? A. Migratory arthritis, rheumatic fever. B. Simultaneous arthritis, rheumatoid arthritis. C. Chronic symmetrical additive peripheral polyarthritis, rheumatoid arthritis. D. Chronic asymmetrical polyarthritis, psoriatic arthritis. E. All of the above. Again, you may pause the video. I won't pause the video because it's going to end up being a very, very long thing. So remember, I say that whenever you see that two options that you are really sure of and then you have an all of the above option, it's most likely that it's all of the above. So you do see migratory arthritis in rheumatic fever. You do see a symmetrical affected joints in rheumatoid arthritis, and you do see this as a chronic additive peripheral polyarthritis. And then, of course, in psoriatic arthritis, they are asymmetrical. So all of the above. So question 19, the following are true in relation to signs in rheumatoid arthritis except A. Ulnar deviation is noted at the wrist joint. B. A fixed flexion occurs at the proximal interphalangeal joint. C. Hyperextension occurs at the proximal interphalangeal joint. D. Prominent tender ulnar styloid process. E. Lateral deviation and overriding of the toes. They're asking you which of the following is incorrect, in short, or in essence. So remember that there are some special signs that you see in rheumatoid arthritis. There is what is known as a Boutonnière's sign, which is what is described by option B. There is what is known as a swan neck deformity, which is what is seen in option C. But you do not get ulnar deviation at the wrist. You get radial deviation rather. So the answer there would be A. The ulnar deviation is at the fingers. Okay. Question 20. Which of the following defines Felty syndrome? A. Rheumatoid arthritis, enlarged spleen and neutropenia. B. SLE, enlarged spleen and neutropenia. C. MCTD, splenomegaly and leukopenia. D. Rheumatoid arthritis, enlarged spleen and lymphopenia. E. SLE, enlarged spleen and lymphopenia. Again, this is also one of the questions where if you have come across it, you do know what it is. If you haven't come across it, you don't know what it is. So obviously the answer here will be A. Rheumatoid arthritis, enlarged spleen and neutropenia. Comment in the section below about what Felty syndrome is for those that do not know about Felty syndrome. And also subscribe to the channel. Hit the like button. Do I have to remind you every single time? So moving on to question 21. A 50-year-old smoker presents with a history of a cough that is productive of mucoid sputum in every winter for the last 3 years. The most likely diagnosis is A. Bronchial asthma, B. Chronic bronchitis, C. Bronchiectasis, D. Bronchogenic carcinoma, E. Cardiac asthma. Again, you may pause the video if you may, but you have this history of someone who's smoking. Of course, yes, smoking predisposes you to bronchogenic carcinoma, but you would get a characteristic feature of blood in the sputum. So you would get a history of bloody sputum. And with asthma, why would an asthmatic be smoking? That's like killing yourself slowly. Anyways, cardiac asthma is not really the asthma that you think it is, but it's rather these asthma-like symptoms that are going to be arising because of failure of the heart or whatever pathology is happening in the heart leading to congestion of the lungs. So it's not really asthma per se. So the answer obviously here would be chronic bronchitis. That's someone who's having this chronic, persistent, productive cough for the past 3 years, and of course in a consecutive number of months. In the diagnosis of rheumatoid arthritis, one of the diagnostic tests is ACCP and ACPA. This stands for A. ACCP anti-citrulinated common peptide, B. ACCP anti-cyclic citrulinated peptide, C. ACPA anti-citrulinated positive antibody, D. ACPA anti-cyclic peptide antibody, and E. None of the above. You may pause the video, but ACCP, the answer here would be B, which is anti-cyclic citrulinated peptide. Sorry, I almost said A. So the answer here will be B. Of course, this is going to be the diagnostic test that's going to be used in rheumatoid arthritis. Remember that rheumatic factor is not really specific to rheumatoid arthritis. It's also seen in other conditions. Question 23. The following are extra-articular hematological manifestations of rheumatoid arthritis except A. Anemia, B. Thrombocytosis, C. Leukopenia, D. Lymphopenia, E. Thrombopenia. I think that should have been thrombocytopenia. The answer is D. Lymphopenia. You do get features of anemia. You do get features of either thrombocytopenia or thrombocytosis. You get a neutropenia, not a lymphopenia. That's a drop in the neutrophil count. And usually these are what I'd like to call an opposite variation. Whenever you get a drop in the neutrophil count, the lymphocyte count usually tends to rise. Whenever you get a drop in the lymphocyte count, the neutrophil count usually tends to rise. But of course, this is not a rule that is set in stone. Sometimes you may get features of bone marrow failure, where you may get a drop in both the neutrophil as well as the lymphocyte count. Moving on to question 24. The following statements in relation to hepatitis C are correct, except A. It is a double-stranded RNA virus. B. Acute infection is often subclinical. C. There is significant risk of hepatocellular carcinoma. D. Blood transfusion is an important source of transmission. E. PCR provides a direct measure of viral replication. Recall that hepatitis C is part of the hepatitis viruses. Remember that you have hepatitis virus A, B, C, D, and E. Then, of course, hepatitis virus A and E are pretty similar. They usually cause an acute self-limiting infection. Hepatitis B and C are often transmitted the same way through either sexual contact with infected body fluids, through sharing of needles, blood transfusions, and organ donations. And then hepatitis D is a defective virus, which often needs the help of hepatitis B. So you need a co-infection with hepatitis B to actually contract hepatitis D if it's present. So hepatitis C is an RNA virus. It's a flavivirus. It does cause an acute infection. It also has a propensity to cause a chronic infection and also puts people at risk of developing hepatocellular carcinoma. In the process, it can be transmitted through blood. But of course, PCR is not a way of judging the viral replication. It's actually a way of detecting the presence of the virus in the sample. So it's most likely E is the answer here. Question 25. A 33-year-old man is brought into the emergency department with fever, lethargy, confusion. He is cachexic, man in acute distress, unable to respond to questions or follow commands. His friend confides that the patient has been sexually active with multiple partners and was diagnosed with HIV several months ago, but was lost to follow-up. Based on prior records, his most recent CD4 count is 65 cells per microliter of blood. What next are you going to do? A. Recheck the CD4 HIV viral serologicals. B. Do a lumbar puncture. C. MRI brain with contrast. D. CT head without contrast. And E. Neurological exam with fundoscopy. I know 90% of you are going to get this question wrong, and you're probably going to be arguing with me in the comment section below. But anyways, let me explain before I give you the answer. So this is a patient that is, of course, HIV positive. You already determined that the last CD4 count is 65 cells. So you have already established that this person has a very low CD4 count. And the fact that they have been sexually active means they could have contracted something. And if you are presenting to you with confusion, lethargy, fever, we're not really getting any features of meningism per se. Okay? You would get features of neck stiffness, the triad, fever, neck stiffness, and in some cases you may get photophobia, then you would think in the lines of meningitis. But this is a person that's not having any neck stiffness. Of course, yes, there is some confusion, there is some fever and lethargy, but you could get confusion, fever and lethargy in almost any other condition, not really meningitis. So that's why I wouldn't want to do a lumbar puncture to begin with. And again, the confusion could be a sign of increased intracranial pressure. I also wouldn't want to do a lumbar puncture. Again, if you're suspecting meningitis, you wouldn't rush to do a lumbar puncture before you do other investigations quickly to rule out other causes. There's no point in checking the CD4 count again or doing a viral load, because if you are doing your CD4 count and the CD4 count is low, obviously the viral load is going to be much higher. And of course, now we are doing viral loads as a proxy to actually monitor the progression of the disease, because they are actually research has shown that they are actually much more effective than monitoring the CD4 count. Then you wouldn't want to order an MRI brain scanner with contrast, because again, there would be features of increased intracranial pressure, and again with a mass that may be present. If you're thinking maybe there's a pathology and a CNS OI that may be present in this patient, again, if you go in with your lumbar puncture without actually ordering any imaging, then you may predispose this person's brain herniating. Okay, so most likely you first want to do a full neurological examination, because they haven't told you that they've done a full neurological examination in this patient. They haven't mentioned any of that. Like I said, there are no features of neck stiffness that have been mentioned. Kerning sign, Brzezinski sign, cranial nerves, and all those things, they haven't been checked in this patient. And of course, fundoscopy, which may show you papilloedema in cases of increased intracranial and intraocular pressure. So obviously the answer is E. Argue with me in the comment section below. Question 26. A 40-year-old lady presents with history of severe constant upper abdominal pain that does not radiate and is associated with vomiting. On examination, temperature is normal and there is marked tenderness in the epigastrium. The most useful investigation for this patient is A, cardiac enzymes, B, electrocardiography, C, gastroscopy, D, liver function test, E, serum amylase. So this is just simply testing you the differential diagnosis of someone presenting to you with upper abdominal pain that doesn't radiate and is often associated with vomiting, and it's of course in the epigastrium. So most likely this is going to be associated with a GIT problem. So you want to do a gastroscopy to actually see what's going on in this patient. Question 27. An important physical sign of portal hypertension in a patient of cirrhosis of the liver is A, gynecomastia, B, hepatomegaly, C, palmar erythema, D, spider angioma, E, splenomegaly. Here's another question which I think potentially people are going to argue with me in the comment section below. But anyways, here comes the answer. So it's obviously a feature, splenomegaly is obviously a feature of portal hypertension. Gynecomastia is a feature of liver cirrhosis. Okay, and pretty much estrogen buildup in the body because it's not being broken down by the liver. Then, of course, hepatomegaly is not really a typical feature of cirrhosis. Palmar erythema, just like with gynecomastia, also due to metabolism that's affected in the liver. Then, of course, the spider angioma also related to cirrhosis, but rather the more typical feature that will show you that there is portal hypertension in a patient with cirrhosis, not just the patient with cirrhosis, but portal hypertension with cirrhosis is of course going to be splenomegaly. Question 28. A 30-year-old HIV-infected patient presents with a dry cough of 2 weeks duration, weight loss, and night sweats. Abdominal ultrasound reveals hepatosplenomegaly and chest x-ray revealed symmetrical nodules. The most likely diagnosis is A, miliary tuberculosis, B, a chronic liver disease, C, malaria, D, pneumonia, E, typhoid. At least if you are marking yourself, you should get 1 out of 50. I expect each and every one of you to get this correct. So most likely this patient has miliary TB. If you do not know what miliary TB looks like, then just have a Google of that. So question 29. In a patient with history of jaundice, pruritus, or pruritus, and clay-colored stool, which of the following enzymes level is expected to be markedly elevated? A. Alanine aminotransferase. B. Alanine phosphatase. C. Aspartate aminotransferase. D. Lactate dehydrogenase. E. Pyruvate kinase. So obviously this is testing you to see if you know the diagnosis here. Most likely this patient has obstructive jaundice. Remember that the features that are going to be pointing you towards obstructive jaundice are going to be dark colored urine, which is Coca-Cola colored, a pale stool, which can also be described as clay colored stool. You also get itchiness of the skin and scratching of the skin, that's pruritus. Then of course your jaundice. So most likely this is going to be an obstructive type of jaundice, and often the obstructive type of jaundice is associated with an increase in ALP, which is alkaline phosphatase. Remember that this is not just limited to patients that have these pathologies, but ALP can actually be raised in patients that have bone tumors. So you should exclude bone tumors before you actually think that this patient has obstructive jaundice. Question 30. With regards to HIV microbiology, which of the following statements is true? A. ENV or envelope gene leads to the production of GP160, which is cleaved to produce GP120 and GB41. GP120 or glycoprotein 120 attaches to the patient's CD4 T cells. GP41 leads to fusion and entry into the immune cell. G group and group specific antigen gene leads to production of P24 and P17. E, all of the above. Again, you really have to know the morphology of HIV. Remember that HIV has these spikes on its surface. So these spikes are pretty much glycoproteins. You have glycoprotein 120 and glycoprotein 41. Glycoprotein 120 is actually the one that's going to be attaching to the receptors that are found in the CD4 T cells. And then, of course, the glycoprotein 41 is a fusion glycoprotein, so it also aids in the fusion and entry of the cell, of the virus into the cell. Then, of course, indeed, these envelope gene does code for the GP160, and the group-specific antigen gene codes for P24 and P17. Remember that antibodies against these proteins are the ones that we're going to be using for the diagnosis of HIV. Then, so most likely it's all of the above. Okay? So again, if you're really sure about two options and you have an all of the above option, then it's most likely an all of the above answer. I don't have to tell you all the time. So question 31. Sorry for the bulky question. A 46-year-old man with HIV CD4 of 77 millimeters, 77 cells per cubic millimeters of blood, hypertension, hyperlipidemia, and osteoarthritis, presents with sudden weakness of his right hand. Okay, he reports that the weakness has gradually been getting worse and that this morning he dropped his cup of coffee. He has never had anything like this happen to him before. He reports inconsistent adherence to his home medication, which includes raltegravir, tenofovir, emtricitabine, trimethoprim and sulfamethoxazole, hydrochlorothiazide, pravastatin, and occasional ibuprofen. The patient's temperature is 39.2, blood pressure is 156/92, pulse is 88, and respirations are 18 breaths per minute. On neurological examination, he has 3 out of 5 strength in the distal muscles of the right extremity with preserved sensation. His neurological examination is normal in all extremities. Which of the following is the best next step in the management? A. A lumbar puncture. B. Serology for toxoplasma-specific IgG antibodies. C. Head CT. D. Empirical treatment with pyrimethamine sulfadiazine. E. Empirical treatment with itraconazole. Okay, so this is a patient that's HIV positive again, and they are not really taking their meds. They're also hypertensive and they have hyperlipidemia and osteoarthritis, so many comorbidities. And they're presenting to you with features of 4 neurological symptoms. That's the weakness in the right hand, and of course stiffness that's gradually getting worse. But of course that could also be attributed to the osteoarthritis. Then, yeah, those are the most significant things. The reduced power, of course, on the distal muscles on the right extremity. So there are some focal neurological symptoms, but you do a neurological examination of the other limbs and they are normal. So most likely you want to do a head CT to find out what's going on if there is a focal lesion. So most likely this patient could be suffering from toxoplasma. You wouldn't rush specifically to go for the serological test before you actually do a CT scan, because there are other things that may present to you in a similar fashion. So you first want to get some imaging. Question 32. Tophi are frequently seen in all the following except A, ears, bursa, tendon sheaths, elbows, E, none of the above. You may pause the video at this moment. Again, this is one of the questions where you either know it or you don't. So most likely this is none of the above, because tophi, which are seen in gout, can be seen in all of these tissues and all of these structures. Question 33. The drug of choice in an acute attack of gout is A, NSAIDs, B, allopurinol, C, colchicine, D, pethidine, E, paracetamol. So most likely this is going to be NSAIDs. Allopurinol is not really used for pain management because the hallmark of the acute gout attack is to manage the pain. So allopurinol is not really for pain management. Colchicine is an anti-inflammatory. Pethidine is not really used for acute unless if you want to escalate the patient. But usually we start off with the NSAIDs. Of course, paracetamol won't be as effective. Question 34. A 19-year-old girl has difficulty in combing hair and climbing upstairs since 6 months ago. She has Goer's sign positive and maculopapular rash over metacarpal joints. What should be the next appropriate investigation to be done? A, ESR, B, rheumatoid arthritis factor. Rheumatoid factor, rather, not rheumatoid arthritis. Rheumatoid factor. I think I'm tired. Creatine kinase, electromyography, E, serum potassium. You may pause the video at this time, but here comes the answer. So this is most likely creatine kinase. So there is some pathology that's going to be, of course, affecting her muscles, and it could be that this child probably has a muscular dystrophy, or they could have a connective tissue disorder, as this may be part of its manifestation. Question 35. A 30-year-old man is found to be hepatitis B surface antigen positive on a routine biochemical test. He is asymptomatic. On examination, there is mild hepatomegaly, alanine transferase, which is that's supposed to be alanine transferase, which is ALT, is 200, and hepatitis B DNA is positive by polymerase chain reactions. The oral antiviral agent of choice for this patient is A, acyclovir, B, amantadine, C, adenovirus, D, ribavirin, E, zidovudine. Again, this is one of the things that if you have come across, you would know. If you haven't come across, you wouldn't know. So adenovirus is actually the antiviral that can be used in the management of patients with hepatitis B. Question 36. Why is it necessary to co-administer vitamin B6 pyridoxine together with isoniazid? A, vitamin B requirements are higher in tuberculosis patients. B, isoniazid causes decarboxylation of carboxyl groups in vitamin K-dependent enzymes. C, isoniazid interacts with pyridoxal phosphate. D, isoniazid causes malabsorption of vitamin B6. E, isoniazid causes a conversion of homocysteine to cystathionine. So remember that vitamin B is often given with patients that are taking TB, especially those that are on isoniazid. Remember that the complications of TB drugs, you have the different types of TB drugs are rifampicin, isoniazid, pyrazinamide, and ethambutol. And of course, rifampicin discolors your body fluids. It's hepatotoxic. Isoniazid causes peripheral neuropathy and is also hepatotoxic. Pyrazinamide is going to be associated with hyperuricemia and it's also hepatotoxic. And of course, ethambutol is associated with optic neuritis. But the main reason why we give vitamin B6 is because isoniazid actually interacts with pyridoxal phosphate. So that's what is going to be leading to your peripheral neuropathies. That's why you want to cover these patients on vitamin B6. Question 37. Which of the following is not an inflammatory arthritis disease? A, psoriatic arthritis, B, rheumatoid arthritis, C, osteoarthritis, D, lupus-associated arthritis, E, post-inflammatory infectious arthritis, Rheumatoid syndrome. So which of the following is not an inflammatory arthritis disease? Again, this is one of the things, if you have read these conditions, you'd know the answer. If you haven't, you wouldn't. Most likely this is E, post-infectious arthritis or Rheumatoid syndrome. All these other conditions are inflammatory conditions. Question 38. Typhoid fever is characterized by which of the following statements? The illness is usually acquired from inhalation. Wow. Leukocytosis occurs in acutely ill persons. C. Rose spots are usually present at the time when the fever begins. D. Chloramphenicol is effective in preventing relapse. E. Fluoroquinolones, antibiotics, eradicate the organism even in the presence of gallstones. Again, you may pause the video, but most likely the one that makes the most sense to me is, of course, option E, the fluoroquinolones eradicating organisms even in the presence of gallstones. Chloramphenicol is not so effective. There's actually been some resistance that we have noted. And of course, leukocytosis doesn't really occur. You may sometimes get a drop in the white blood cell count. And then, of course, it's acquired via the fecal-oral route. Then, of course, the rose spots, they don't present at the time when the fever begins. Then question 39. A 65-year-old male with pneumonia has a sputum culture that is positive for Staphylococcus strain, but is beta-lactamase positive. Which is the best choice of penicillin therapy in this patient? A. Ampicillin, B. Oxacillin, C. Ticagrelin, D. Penicillin G, E. Carbapenicillin. And here comes the answer. So it's obviously oxacillin. Oxacillin is the one that's going to be used for it's actually resistant to beta-lactamase. Remember that beta-lactamase is this enzyme that bacteria possess that actually breaks apart the beta-lactam ring, which renders most of the penicillins ineffective. So usually if you get this methicillin-resistant Staphylococcus aureus or penicillin-resistant Staphylococcus aureus, it can be a menace, especially in hospitals. Question 40. Which of the following statements is true concerning treatment of post-primary tuberculosis? A. Combination drug therapy is always indicated. B. Sputum remains infectious for at least 4 weeks after the onset of therapy. C. At least 12 months daily therapy is required for 100% effectiveness. D. Isoniazid and pyrazinamide do not cross the blood-brain barrier. E. Treatment failure is invariably due to multiple drug resistance. Okay, so let's think through each of these options, starting with option E. Okay, so treatment failure is not always due to multiple drug resistance. You get other factors like compliancy issues. You get other factors like antidosing that may be there. Okay, then isoniazid and pyrazinamide, they do cross the blood-brain barrier. And then remember that TB can also, uncomplicated TB is actually treated for 6 months. Then, of course, sputum doesn't remain infectious for 4 weeks. It's actually much less than that. Then combination therapy is always indicated. Remember that you have 2 phases when you're treating TB. You have what is known as the intensive phase, where you use the drugs rifampicin, isoniazid, pyrazinamide, and ethambutol. Then, of course, you have the continuation phase, or the intensive phase or the initiation phase, and then the continuation phase, which is, of course, you drop off 2 drugs and then you remain with rifampicin and isoniazid. So the answer, obviously, there will be A. Question 41. A 25-year-old British medical student is doing an international health elective in Chongwei studying tropical disease epidemiology as part of his pre-trip preparation. He wants to be protected from malaria and is researching on options for prophylaxis. Which of the following agents should be avoided for malaria prophylaxis in this patient? A. Chloroquine, B. Mefloquine, C. Advaquan, D. Doxycycline, E. Quinine. Again, if you live in a malaria endemic area, this question is very easy. Or if you're studying tropical medicine, this question is actually very easy. So most likely quinine is the one that we do not use quinine for malaria prophylaxis. We can use all these other prophylactic drugs, but remember they also work against certain species. If you're in a certain area where you have a predominant type of malaria, for example in Chongwei, where you have a predominant Plasmodium falciparum, or the other malaria drugs may become ineffective. Question 42. In renal medicine, which of the following is false? Oliguria is defined as excretion of less than 500 mils of urine per day. HIV-associated neuropathy presents with proteinuria in nephrotic range. Antiphospholipid syndrome can have renal involvement with proteinuria. D, renal failure can occur in patients with multiple myeloma. E, polyuria is not a common symptom of urinary tract infection. Again, this is a giveaway. The one that seems not to be true is polyuria, not common in urinary tract infection, because it is common in urinary tract infections. Question 43, chronic renal failure, which is false, can present with nocturia. Infertility can occur. Complications include risk of peptic ulceration and acute pancreatitis. D, anemia can be associated with bone marrow fibrosis. E, pruritus does not occur. So the answer that is incorrect here is, of course, E, pruritus does not occur. It does occur because you have uremia, and uremia is often accompanied by itching of the skin. Question 44, we're almost towards the end, so if you still haven't yet hit the like button, please let's smash the like button and get this video to as many likes and as many views as possible. Keep inviting friends to the channel. Question 44, a 40-year-old diabetic man presents with history of sudden onset of pain in the right loin, which radiates towards the right iliac fossa. You guys are going to fight me on this question. It is associated with fever and vomiting. On examination, tenderness is present in right loin. The most likely diagnosis is A, appendicitis, B, cholecystitis, C, diverticulitis, D, perforated peptic ulcer, and E, pyelonephritis. When I released this question in one of my handouts, I think I had a big argument with someone concerning the answer, but I think I still stood my ground. So you get a patient that has a history of pain in the right loin, that is radiating, of course, to the right iliac fossa. It's very, very tempting to want to say that this patient has appendicitis, right? It's very, very tempting. But of course, that wouldn't be your answer, because appendicitis doesn't radiate. It's a pain that migrates. So the answer here obviously will be pyelonephritis, okay, which is urinary tract, an upper urinary tract infection. Question 45, a 55-year-old girl is brought to the hospital by her mother, who gave a history of swelling of the body that started on the face on waking up in the morning. Her blood pressure was normal and the JVP was not raised. She had ascites and bilateral pleural effusion. What is the first line investigation you would request? A, urea levels, B, chest x-ray, C, echocardiograph, D, urine albumin, E, liver enzymes. Again, I've given you the typical diagnosis in the question. So this is a woman that's waking up with swelling of the face, ascites. So obviously, whenever there's edema, you should think that there's either a problem with the heart, a problem with the liver, a problem with the kidneys, or a problem with the diet. Okay, if it's a high malnutrition, for example, or it could be heart failure, or it could be chronic liver disease, or it could be a gastrin losing enteropathy, or it could be a nephrotic syndrome. Most likely, this is typical of nephrotic syndrome, of waking up with swelling of the face. So you want to order for urine albumin. Question 46. A 58-year-old African man presents with pitting edema of his ankles. He suffers from recent diagnosed hypertension but is otherwise healthy. Blood results show low albumin and urine dipstick is positive for protein. The most appropriate initial treatment is A, high protein diet, B, diuretics, C, prophylactic anticoagulation, D, ACE inhibitor, E, bed rest. So you may pause the video at any point, but here comes the answer because we're toward the end, so I will a bit speed up my pace. So this is a patient that has pitting edema. So obviously we do agree that there is something wrong with either his kidneys, his heart, his liver, okay, or the GIT. So he suffers from recently diagnosed hypertension, so we rule out the liver. We rule out the GIT as well. We remain with the heart and the kidneys. And urine dipstick is positive for protein, so that means most likely it's the kidneys. So most likely this patient has a nephrotic syndrome. And remember that ACE inhibitors are going to be protective in patients with nephrotic syndrome. And here you're going to be killing two birds with one stone, because you're going to be helping with the hypertension as well as helping reduce the proteinuria and preventing the progression of the kidney disease. Of course, so yeah, the answer would be D. Question 47. The following are cutaneous manifestations of diabetes except A, eruptive xanthomata, B. necrobiosis lipodicum, C. bullae, D. erythema nodosum, E. granuloma and I'm not going to pronounce that. And here comes the answer. So it's obviously erythema nodosum, which is not a manifestation of diabetes mellitus. All the others are manifestations of diabetes mellitus. Question 48. Which of the following is not an important hallmark of Graves' disease? A. hyperthyroidism, B. exophthalmos, C. pretibial myxedema, D. lid lag, E. none of the above. So recall that Graves' disease is actually an autoimmune condition where you produces TSH-like antibodies that often stimulate the thyroid gland and cause an increase in the production of T3, T4, and also stimulate the thyroid gland to undergo hyperplasia and hypertrophy. Remember that these TSH-like antibodies can actually also stimulate fibroblasts to proliferate. They may stimulate the fibroblasts to lay down matrix, and this is what is going to be essential for the premixual edema. And then there may be some tissues that may be laid down behind the eye, pushing the eyeball forward, leading to the exophthalmos and the lid lag. Of course, hyperthyroidism is not really a hallmark of Graves' disease because there are other conditions that it may present with. So most likely hyperthyroidism. Question 48. Other common causes of hyperthyroidism other than Graves' disease include all the following except A. thyroiditis, B. toxic multinodular goiter, C. toxic adenoma, D. medication side effects, E. none of the above. So they're just pretty much asking you which of the following does not cause hyperthyroidism. And here comes the answer. You may pause the video now. So most likely it's none of the above because they all do cause hyperthyroidism. The last and indeed the final question to send you off with this pilot episode. I hope you really enjoyed. So a 25-year-old man presents with heat intolerance and recent weight loss. Serum analysis shows increased levels of T3 and T4, as well as the presence of thyroglobulin stimulating immunoglobulins. The patient is found to be tachycardic and has marked edema and waxy discoloration in his legs. Which of the following would be consistent with the patient's disease? A. sympathetic underactivity, B. antithyroglobulin antibodies, C. exophthalmos, D. increased TSH release, E. multinucleate giant cells present in the thyroid gland. So think about this question. Scream your answer at the screen. Pause the video if you may. And the final answer to this first episode of Who Wants to Be a Millionaire? I'm just kidding. I'm a Shortgun QnA is, of course, exophthalmos. So this is going to be presenting with this disease because, as we can see, there's already pretibial myxedema that they have described. So most likely exophthalmos is also going to be present. If you liked this video, subscribe and help me out. Hit the like button. Drop a comment in the section below. Let's make your dreams come true. Share this video to everyone that's writing exams to Zambia and beyond. My name is Dr. Moses Kazevu.